I am a community development researcher at the Federal Reserve Bank of San Francisco. I was also an editor on this book. Thank you.
I've never done one.
Thank you. I have fans. No, that's not true. So I just wanted to take a minute and actually acknowledge my fellow editors on the book. You've heard from David. You heard from Jen. Anthony's at home with his beautiful baby. But I'd like to ask Valerie Bartlett and Janet Genzer to stand up and be acknowledged for their contribution as well. Thank you. If you're not on the agenda, you don't get thanked. So those. Before I sort of launch into the targeted talks portion of the agenda, I just wanted to spend a couple minutes on the architecture of the book. I'm sure you've all read it, so this is all old hat for everybody, no doubt. But if you haven't, the book is divided into sort of three buckets. The first bucket is really how did we get to this conversation about outcomes-based funding and financing. The second bucket is kind of a grab bag of op-ed style perspectives from literally dozens of perspectives in the field. And the third section is a synthesis and some look forward about what's coming next and what needs to change across all of our fields to get to the outcomes-based universe that we want to arrive at. So that's kind of how the book holds together. In my opinion, the middle section is where the action is. That's really where you get the most diversity of opinion. It's not all a cheerleading outcomes-based funding and financing. There are some critics in the mix, and to me, it's the vitality, the most vibrant portion of the discussion is that middle section, and this portion of the agenda, the targeted talks, we're going to hear from 4 people here briefly, is really supposed to take on that character. It's supposed to provide kind of a snapshot of individual perspectives on why outcomes are important and how we get there. So that's why we designed the agenda today the way that we did, to mirror the book. Before I introduce Tyler Norris, I just want to remind everybody, if you have questions, please fill out your cards and hold them up. I know we're probably not going to get to all of them, but I'll do my best to get to as many of them as I can. So without further ado, Tyler Norris is the Chief Executive of Wellbeing Trust. Personally, I think that addressing the social determinants of health is the future of the community development industry and anti-poverty work generally. Tyler lives at the frontier of that work. He's going to talk a little bit about his chapter in the book and more broadly about how we can actually create a market that values better health outcomes instead of just health care. So Tyler, come on up.
Thank you, Ian. Good afternoon, everyone. A delight to be here, to have been invited to be part of the book and to follow such a rich conversation that reminds us that transpartisanship is possible in this country. I find this a time of historic opportunity where we know that further tinkering at the margins of little programs and little projects here and there, 2- and 3-year grants that come and go, well, it hasn't changed the needle yet, will not add up for the health and well-being of this country. And that what we need to be able to do together, across sectors, across points of view, perspectives, parts of this extraordinary nation, is to craft an investment and a policy strategy that is capable of propelling us to a strong third American century. An investment and policy strategy. That is the focus point of our new foundation, Wellbeing Trust, part of a $1 billion commitment of the Providence St. Joseph Health System to improve the mental, social, and spiritual health of the country. And for us, it's part of how do we convene and coalesce to create a strategy for this nation that's worthy of who we are as a nation. But I have to admit, I stand here before you as part of the healthcare sector, I know you know we're the folks that soak up 18% of our nation's GDP, almost 20 cents on every dollar, and return population health outcomes at the very bottom of all developed nations in the world. That's the return on investment that our healthcare sector gives you. But that's not to disparage our sector, because if you have coverage, we deliver the finest care that money can buy. But it has to say that we need to partner in very new ways if we're going to create a measurable impact on health. In the previous century, the lifespan of Americans expanded 24 years. A recent report from the Institute of Medicine told us that after that century, in the current period, children are likely to live 5 years less than their parents. Now, 24 years, that's how old my daughter is that I had dinner with last night, and I'm going to have dinner with again tonight. Here's Eliza's phrase to me, because I've been working on community health improvement her whole life, and before that, what have you been doing? Right? Because, as she reminds us, this is on our watch. And that's what we have handed her and her brother and all of our children and grandchildren, etc. So what I'd like to do is to shift this conversation for the health sector in partnership with all of you of how do we move from doing good things with billions in community benefit and all the good stuff and grants we do to doing good things to being accountable for outcomes. Now, in honor of our resident historian, David Erickson, describing the years leading up to the French Revolution, which would, of course, culminate in the Jacobin Reign of Terror, Charles Dickens wrote in A Tale of Two Cities, it was the best of times, the worst of times, the age of wisdom, the age of foolishness. It was the epoch of belief, the epoch of incredulity, right? We all know this. We had everything before us. We had nothing before us. That's where he left us. 75 years later, F. Scott Fitzgerald said in The Crack-Up, the test of a first-rate intelligence is the ability to hold two opposed ideas in mind at the same time and still retain the ability to function. So that's really where we are as we face a period where we can currently hold a polarity, if you will, of incredible uncertainty on some matters, like some of the policy conversations we've just had, and yet momentous certainty on other things about what actually improves health. So first, the uncertainty. Now, we seem to have sort of dodged the bullet on pulling healthcare away from 23 plus million Americans for the moment. But I would be very cautious about thinking that that somehow is beyond. Because what we learned is that anything less than 100% access to care for all Americans will diminish population health. It will, in fact, happen. And if you pull people away from a medical home, it doesn't mean people don't get care. It just means it's not reimbursed. And as a representative of the health sector most of my life, I can tell you, you're going to still pay for it. It's just going to get cost shifted to other payers. There's no savings here. That's a shell game to think that that's going to happen, right? And we know that if we don't have 100% access to care, you will lead to greater acuity of disease, there will be more indirect costs to employers and society, and you place more and more Americans one illness away from bankruptcy. That's where that strategy actually takes us. You pull back the essential health care services that are part of the Affordable Care Act at a time when mental health and substance use, 55,000 people die of opioid overdose in the last year, and historic rates of suicide. All you're going to do is actually spend more money and decrease health at the same time. That's what you get from an alternative track. But that's just the healthcare side of the equation, while you zero out the public health fund and such things. While access to care is vital as an economic matter and arguably as a moral matter in this nation, it's equally devastating in that most of what creates health is outside of the healthcare delivery system, having to do with the determinants of health, as Ian has described. It's devastating to think about cuts in the 15 to 25% range for HUD, the EPA, early childhood and education funding, the Childhood Nutrition Act, which is coming up for reauthorization. Because what we do when we move in this way is that we underproduce the factors that produce health in the first place, which is education, living wage jobs, housing with supportive services, transportation and access to mobility, to jobs, to school, to life, right? That's it. Housing policy and investment is health policy and investment. Transportation policies and investment are health policies and investment. Community development finance, living wage jobs, healthy food policy, community safety, green jobs. This is health policy. You want to improve health, that's where you invest. That's the leverage point on improving health. I grew up in the state of Idaho, rural America, where an old rancher I knew as a kid once told me when he saw the kind of foolishness that we've been talking around here. He said, "Tyler, it's like eating your seed corn. It's a desperate measure that may get you a little quickie today, but it simply pushes until tomorrow and the next generation what will become an even greater disaster." So secondly, what about the certainty? While we spend $3.2 trillion a year on healthcare services, making the U.S. healthcare sector the fifth largest economy in the world after the U.S., Japan, Germany, and France. And most of us in this room likely have access to the best care money can buy, right? Fair enough, right? Not necessarily everybody. We, among the most developed nations, rank 11th. And in key global measures such as child mortality, we're in the 30s, right? And if we value a return on our healthcare spend for the benefit of the health and well-being of American people, improving creativity, improving productivity, our investment portfolio is out of balance. So the question is what does it do when we have an overinvestment in profitable care services and an underinvestment in what creates health? So what we know is that it crowds out, the investments in healthcare essentially crowd out the investments in what produce health, as we were talking about a bit ago. So to contain costs and change the odds for middle-income Americans and families across the country, we have to redirect our healthcare spend towards the health and human services upstream from health that actually produce health in the first place. That's going to take partnership with sectors that we have not worked with, the healthcare sector has not worked with. When I wrote the chapter, I worked at Kaiser Permanente, one of the nation's leading nonprofit health systems. I love Kaiser Permanente and the organization, and particularly its business model, because by owning the risk of 11 million members, Kaiser Permanente does better when people are healthier. What that did is it turned Kaiser Permanente and many health providers who are increasingly going at risk through shared payment agreements, through at-risk arrangements, into purchasers of health. Not suppliers of health, but purchasers of health, with the producers of health being what community does. Housers, food growers and distributors, people who create living wage jobs, etc. That is the shift of how we start to think about who is a producer of health and who is a buyer of health that matters. A few things we know. Place matters. I knew in Kaiser Permanente that 1% of our members concentrated in some small neighborhoods drove 29% of our costs. 5% of our members in targeted neighborhood, 50% of our costs. That's not just money, that's very significant human suffering. Equity matters. 1 in 2 Latinos and African Americans born today will be a diabetic at current rates. That's higher by 50% than Anglos. And third, that incentive matters. We have to shift the incentives to beds empty, not beds full. You can't have a $3 trillion sector that profits from more throughput and try and save money. So what does that mean? 5 things. We need to assure that everyone has access to a medical home, primary care, and preventive services. That's job one. 5 to 1, maybe 7 to 1 return on investment. Secondly, we need to make sure that our grants, and thanks to Eric, where he may go, talking to us of his funders, that we have sufficient dose, reach, intensity, and duration in our grants to have a population-level health impact. Because for the most part, many of the grants made do not have sufficient dose, and then we sit back and say, why hasn't it worked? It is unethical to continue to make grants that we know don't add up. Third, we need to make the assessment and referral to non-medical needs a standard of care, and make those referrals and then pay for them to housing organizations, food producers, et cetera, those who are actually the producers of health. We need to implement anchor strategies where healthcare organizations use their extraordinary role as purchasers, their impact in their investment portfolios, their hiring to drive the local economy. And finally, we have to move from an economic model that values volume to one that invests in the value of care. Nothing less, and this is an important for us here as we celebrate yesterday, a day that marked and changed our nation. What we're talking about is a core part of any authentic homeland security strategy. We know what the issues are, and we know what many of the solutions are. I know we have the resources because we're spending them now. The question is, how do we develop the investment and policy strategies and the community and political will to do what we know we need to do? David started off talking about bright eyes. I'd like to challenge this group to think about, well, what would child well-being or bright eyes bonds look like? What would it undertake if we invested in comprehensive initiatives that provided a range of services for kids? How would we prove that these services reduce future end-of-pipeline costs? And what would it look like to finance these services from long-term savings over time? This is a critical time for leadership and the health and well-being of a nation. If we're going to beneficially impact the health and well-being of people in place and drive strategies for equitable opportunity for all Americans, we're going to have a healthy public policy agenda and investment strategy that values health, not just health care. Thank you.
Thank you, Tyler. So our next speaker is Eshauna Smith. She is the CEO of Urban Alliance, and I think we all agree that the state of the outcomes-based funding and financing world will depend in large part on data and evidence. Randomized controlled trials are going to be a big part of that, and she's going to talk a little bit about her experience with RCTs. Eshauna, come on up.
Thank you. No clapping? Good afternoon. I'm very, very happy to be here. My name is Hashanah Smith. I'm the CEO of Urban Alliance. I want to thank the Nonprofit Finance Fund for having me. I definitely want to give them a round of applause because, yeah, let's give them a round of applause. Because I said that after doing my TEDx talk that I would never, ever give anything called a targeted talk, a TEDx talk, or anything like that again in my career. So they got me up here, and I'm appreciative to them for allowing me to do that. So what I'm here to do is to talk about Urban Alliance's journey with our first randomized controlled trial study. And I was asked to do that because I think we all know how much outcomes matter. And they matter to Urban Alliance, they matter to us a great deal. We want to always make sure that we understand and know how are we doing by the young people that we serve. That's critical to us, right? And our partners, our stakeholders, our collaborators want to know that the time, the energy, the resources that they're investing in Urban Alliance, that they're investing in a place where the work that we do matters and that we do what we say we're going to do. So we know how much outcomes matter. But I think what is interesting about this time for all of us, who do direct service work, lead nonprofits, or however you sort of engage in this space, is that how do you manage through this sort of uptick on outcomes, building your organization's capacity, training your staff, paying for those costs, while at the same time being able to balance, like how do you balance that capacity build and all that you need with keeping your eye on the services that you need to provide for your constituents, for your clients, right? So we want to get better with data. We want to get better with data collection and evaluation, but at the same time, we want to be able to really focus on serving our young people. So how do we do all of that? So I'm going to give you some insight as to how Urban Alliance has managed through thus far. We are not at all finished with our journey. We have excitedly taken on a second randomized control trial study, if you can believe it, but let me talk to you a little bit about the first one. So back in 2011, Urban Alliance had an opportunity to embark on a randomized control trial study, you know, this sort of holy grail of the outcomes movement, this gold standard, this sort of space of, folks are going to come in and objectively evaluate us, and they're going to put one group in treatment and one group does not get the treatment. They're going to condition for all factors that could make anything off or uneven, and then we're going to be able to isolate our impact, isolate our effect. Wow, that's amazing. Isn't that something we all really, really want to do? We want to be gold standard, we want to be high performing, so of course we said yes. We said, yes, we'll do that back in 2011. I come into the organization 2013 as become part of the Urban Alliance family, and I'm like, I struck gold as the new CEO. I'm walking into this organization that's already doing really well programmatically, they're strong, and they've already begun the work on this thing called the RCT. That's great, that's good. I start turning my attention to other things only to have it be turned back. Because while we have survived this thing called the RCT, there is a lot more blood, sweat, and tears. It is not painless, it does not cost, it is not for free, both literally and figuratively. And it took a lot more than I thought. Again, glad to say that we survived, glad to say that we, just 2 weeks ago, rolled out the final results of our 6-year randomized control trial study, which shows that we have a statistically significant impact. Thank goodness. Statistically significant impact when it comes to college access to both the males who complete our program, who are largely Latino and African American, as well as the mid-tier students in our program in that mid-tier GPA of 2.0, 3.0, which is our target population, as well as having significant impact in that we can prove, or it is proven that young people who go through our professional skills training retain those skills over a pretty long period of time. I know I didn't tell you what we do, so I'm going to do that in a second, but we are happy to have gotten these results, and we survived, and we're starting number 2. Urban Alliance was established in 1996, 20 years ago. Here in Washington, D.C., what we do is we provide economically disadvantaged high school students with a 10-month paid internship over the course of their senior year. That work experience really helps them to turn on a number of light bulbs, get some mentoring, some coaching, and some post-high school planning so that they are not disconnected post-high school, that they are onto a track where they can become economically self-sufficient and they are not disconnected from school and or work post-high school, which they are very much at risk of before we get to them. So what I want to do is I'm going to share 3 challenges that we had and 3 recommendations. For those of you who may be considering doing an RCT, you really want to do one, you desire to do so, hopefully this will be helpful for you to kind of hear our journey. First and foremost, as far as challenges, our external relationships, it was hard. They were very strained, not all of them, but particularly when you're walking into a school and you're saying, hey, I need students, and then some of them are going to be turned away because we have to randomize, we have to do a lottery, we have to have this selection process that's different. And you've got guidance counselors and folks who you've worked with UA worked with 10, 15 years saying, what is this thing that's gonna show you something 6 years from now when I have students right now today who need services, who are struggling, who are going home to no one there to support them. Like, it doesn't add up for your partners all the time. So that was really hard for us. And I don't know that we understood going in how hard that was going to be. Some relationships we were able to manage through, some we lost. We can't do this work without relationships, obviously. I'm sure all of you would say the same thing, but everything that we do with our schools, with our parents, with our young people, it's all around relationships, so that's really, really critical. The second challenge, impact on staff. We're asking staff to go out and to double, triple recruit in the face of much disappointment from stakeholders, and then again, knowing that all those young people absolutely won't be able to be in the program this year. So the strain on them, what they have to face into every day, what the kinds of messages they have to be prepared to deliver, how they have to talk about the work. Again, really hard for an organization to face into. We lost some staff that way. And then the third, I think, challenge is fundraising. Someone said earlier, blame everything on the funders. Sometimes that's true, but I'm not gonna go there. What I'm gonna say is it's really hard to fundraise for evaluation. We know we need it. We know it's important, but it's just not. It's not sexy. It's not the thing. It's not the immediate need all the time. We were fortunate to have half of the randomized controlled trial paid for by the Social Investment Fund, but we had to find the rest. We had to find the match, and it was not easy. Thank goodness for long-term funders like the Community Foundation and Meyer Foundation and K-Fritz, who said, hey, we can be a match partner for you. The World Bank was very big with us in that as well. So those are just some of the challenges that we went through. That's just a short glimpse of this journey and how it impacted the organization. What do we recommend? What do we say to people, again, who are in the throes of it, who, like us, are going to embark on a second or third one, who may want to really push themselves around this moment of outcomes and learning more about who you are when it comes to how you're impacting the clients that you serve. One of the things that's very, very critical is you have to staff up. We, like so many organizations, when we first came into this, we had our chief operating officer who was our evaluator, our finance person, and he was the HR head, he was everything, right? And we all know that, and we're like, hey, we'll give you this just one more task. But you can't do that. You really have to find your funders, your investors, your partners who are going to help you staff up, build the capacity to do this work right. So we were very fortunate. And you can even do that if you start off small. We found a graduate student who came to us. He was passionate about this effort, and he was eager and learning. He's in the audience. I won't call him out too much, but he has grown and risen into our director of data and accountability and really helped us to make this journey successful. And we now have 3 full-time folks in the organization who work on data and evaluation. So that's really important. You got to staff up. Secondly, be sure to establish your own internal performance measurement system before you embark on a randomized controlled trial study. The RCT does not take the place of that. You need to understand your own sort of data and evaluation self, your methods, your approach, your philosophy. What do you care about? What don't you care about? What is success for you? What is success for your clients? How do you define that? You want to be able to have that in there so that when you're in the throes of the RCT, when you need to push back on that evaluator, when you need to stand up for yourself, advocate, you have a base to work with because you're doing your own data collection and evaluation, and you understand who you are as an organization in that way. The final recommendation is to over-communicate internally and externally. You cannot educate folks enough about why the study is important, why we need to see 6 years into the future again when folks are hurting right now today. Why does that matter, that we know whether or not this work works? You have to over-communicate that to your stakeholders, to your funders, to your partners, as well as to your team so that they know why this matters and what this means. So I think as we go into the second RCT, that is the one lesson that I think we are definitely going to do much better with this time. I am actually out of time, but I will conclude by saying that it's been up and down a great journey. And I think the one thing that I want to leave you all with is that the RCT is not what's most important. It's about the learning that comes out of it. And I'm very excited that we're in a place now as an organization to embark on a very rich learning agenda. We have lots and lots of information about who we are, what we do well and what we don't do well. And so the challenge for us now, and I think what's exciting and what's the most, sort of the bigger theme here is what are we going to do with that? And how are we going to stand up as an organization to make sure that we take the opportunity that we were given and being able to conduct this RCT, how are we going to be able to, what are we going to show for that? How are we going to do better by our students? Because that's ultimately what this is about, doing better by our young people. So thank you for giving me a moment.
Thank you, Eshauna. So our next speaker is Lisa Fitzpatrick. Lisa is the medical director at the DC Department of Healthcare Finance. Lisa has worn a whole lot of hats in her career. She's an epidemiologist, she's a physician, and she's also a health policy and finance expert. So she's probably the most credentialed person that I've ever met in my life. So Lisa's going to put all of those hats on today and tell us a little bit about how we can navigate to better outcomes in the healthcare sector. Lisa, come on up. Thanks.
Is this thing on? Oh, it's on. Thank you, Ian. I am here specifically and solely because I met Ian at a meeting in Oregon, and I was so thrilled at what he had to say. I cornered him after and I said, the problem is people who give out money, they're not interested in investing in the things you're talking about. And he told me I was wrong. So it's really great to be here, and I can't live up to everything Ian said, but it's been a really interesting journey. And I have slides, don't I? I forgot about that. The other thing I'll tell you is I prepared remarks for this. I was also up at 1 a.m., but I wasn't reading the book. I was changing my remarks because when I read the book, I realized that I'd be preaching to the choir. Because most of the things I read in the book are things that you've experienced, I've experienced, and I didn't want to come here and tell you things you already know. Because I don't like that, and I'm sure you don't like that either. So there's an African proverb. If you want to go fast, go alone. If you want to go far, go together. So I've decided to tell you a little bit about what I believe is possible if we go together. But first I want to tell you just a bit about my journey. It actually starts over here. You can't see the dates, but this is 1992, so I'm probably older than I look to some of you. And I've been around the block. I've worked, as Ian said, across the health sector. If there's been a job in the health sector, I probably have done it. But the reason I'm switching jobs so frequently and so often is because I'm chasing impact. And this is how I feel most of the time, chasing impact. It has been a bit of a frustrating journey, but I'm ready to start focusing on the left-hand side. Or, is that right? Yes, on the left-hand side, over here, outcomes and impact. We are very good on the right-hand side. We've heard a lot about that today. But I think part of the reason we're not so great on the left is because this side is really considered a bit idealistic. This is realistic. This is the stuff we can touch, we can feel. We're comfortable over here, but not so much over here. So I'd like to spend the rest of my time talking about what I think some of the possibilities are. What if we could do these things? That's it. Engage community, tailor services, incentivize partners, and shift culture. That's all. What do I mean by this? Engaging community. Someone's already said communication is an undervalued resource. And I think that is true no matter what we're talking about. It's certainly true in health. The average person in the community has no idea what we're spending our healthcare dollars on, or many of the programs we are implementing. They have no idea. I'll tell you a story about, this story happened just last week. I was running because my doctor told me I have prediabetes. I was devastated. So I decided I'm going to run a 5K, and maybe I'll run a 10K. So I had to start training, obviously, because I don't run. So I'm walking to my friend's house after the run, and a woman walks up to me. I don't know this woman, and she says, "Didn't I see you running up on 8th Street? Why are you running so far? What's going on?" And I said, "Well, I'm training. My doctor told me I have prediabetes, and I don't want to be diabetic, so I have to lose weight, and I have to exercise." And she looked at me, and she said, "Prediabetes. Now, my doctor told me I had that. Now, what is that?" Now, the problem there is her doctor, because he's checked her for prediabetes, he's checked the box. So we would say he's doing what he's supposed to do. And further, she thought he was a good doctor. And I said, "Well, why do you think he's a good doctor?" Well, 2 of my friends said he saved their lives. But still, she didn't know what prediabetes was or how to prevent diabetes. So we spent the next 10 minutes or so talking about diabetes and how you prevent diabetes. She wasn't engaged, but I think she's like the average Joe. So how do we improve the engagement of people in community in our sectors? Second, tailoring services. I think this is really important. It's important to me as a healthcare provider. What if we could tailor healthcare like Amazon tailors your shopping bag? Wouldn't that be great? That'd be incredible. I had a patient who didn't want to come into the clinic. So every person on my team tried to call him to get him to come in. And they said, "Dr. Fitzpatrick, we really need to get him in. He's really sick, but he's afraid to come." So I actually left the office. I called him, and I went to wherever he was. He was on the street somewhere. And we had a conversation right there on the street. I don't have the luxury of time to do that for every single person, but for him, it made a difference. So what if our healthcare and our healthcare system and our funding was flexible enough to enable that type of care? Incentives. We can incentivize our partners, and you can think about what those incentives might be for your sector. But as an example, I'll talk about doctors because that's the group I'm most intimately familiar with. Doctors care about CME, or continuing medical education, because we can't renew our licensures if we don't have it. We care about mitigating liability or vulnerabilities to malpractice. And we care about reimbursement. So if these are our incentives, why doesn't a primary care doctor make as much as a surgeon? Or why doesn't a psychiatrist or an addiction specialist make as much as a gastroenterologist? The incentives are out of whack. I'm hoping that some of you in this room, and it sounds like some of you are, in a position to initiate these conversations so that we can start to improve our incentive structure. And then finally, I just want to talk a little bit about culture, because all the things I've talked about are linked to the culture of our healthcare system, and all those things need to change. But I want to talk a little bit about 3 components. And as an example, I will talk about the budget for the National Institutes of Health. Anybody know what the budget is for the National Institutes of Health? $32 billion. That's annual. It's been increasing, but right now it's about $32 billion. Related to my remarks about communication and educating the community, most people in the public have no idea what NIH does. This is a culture we've created. I'm a fan of science. I've been a researcher. I value data. But at the same time, NIH is funded by, and I'm using them only as an example, NIH is funded by taxpayers. The currency in academia is manuscripts, publications. Some of you already know this. What if every time an NIH-funded grantee published a manuscript in a scientific journal or a peer-reviewed journal, they were required to also publish something for the community describing their research or their science or how it impacts the community? I tweeted Francis Collins about this. He didn't write me back. But maybe if you think it's important, you can help me as well. The second thing is we need to train our workforce. The students who are being trained right now, they're not all being trained to deliver the type of care I'm talking about or to think in the ways I'm talking about. And then finally, I think we have to ask consumers. We have to talk to them about what we're doing. Ask for their advice if we're planning to implement a new program. Is this what people want? Is this what people need? So there's another saying, if you've traveled down a wrong road, turn back. We are speeding down this road in our silos. And the silos are frustrating, but they're also comfortable. So are you ready? Are you ready to change? If you're a decision maker, how important is it to be first or to get the credit? Or if you're a funder, are you ready to take a bigger risk with even less evidence or less data? When I was a girl, my mother would often have me sweep, and I hate to sweep. So I would do a lackluster job sweeping, and she would say, Lisa, don't half do it. If you're gonna do it right. In other words, she was saying, do it full out. I think we've been half doing healthcare and health services up to now. So if you're ready, let's go together and do it full out. Thank you.
Thank you, Lisa. So our last speaker is Scott Kleiman. Scott is a program director at the Harvard Government Performance Lab. He has been embedded in the trenches with multiple governments around the country. So he really has lived this in his experience. I just want to tell a quick story. So we were reminiscing when Scott got here about the last time that we'd spoken. And it's been a while. It's been almost exactly 3.5 years. And he asked me, hey, when was the last time we talked? And I said, actually, I know exactly the last time we talked. It was the day that my son was born. And so we do a conference every couple years, big CRA conference, and we move it around the country. And back in, I guess it would have been 2014, we did it in Chicago. And at the time, Scott was embedded with the governor of Illinois, and Scott had graciously agreed to speak at the conference. And he also mentioned that there was a chance that we could get the governor maybe to say some things at the conference. That didn't pan out, but there was a chance. And it was all really kind of touch and go at the time. And so I'm in the labor room with my wife, and Scott calls. And I turned to my wife, Nicole, and I say, honey, it's Scott, and I have to take this. We're still married, so it all worked out fine. But I think that's the highest praise that I can offer anyone is when Scott called, I would literally miss the birth of my firstborn to speak to him. No, but in all seriousness, the Government Performance Lab at Harvard is probably the most impactful organization in the country in laying the groundwork for this whole outcomes-based funding and financing conversation, and that can't be overstated. This book would not have been possible but for that investment in the field and the technical capacity that they've built over the years. So it's with great pleasure I invite Scott up to the dais.
So I'm expecting a call from Anthony any minute now, given he just had his baby. The second thing I just want to say is that the video at the beginning stole my whole talk, but it's great because you now have a visual to go along with the story I want to tell you. The third thing is that because I'm up here, I get to do this. We've all been sitting for a little while, so I want everyone to stand up. We're going to get the blood flowing just for a moment. Reach to the sky, put your fingers up. All right, now all the way down. Now all the way back up. All right. Great job. I'm done, thank you. So I'm Scott Kleiman. I help run something, as Ian said, called the Government Performance Lab at the Harvard Kennedy School. Many of you may know us. We've done a lot of work around pay for success in governments around the country. And what we're really all about is helping governments tackle their hardest problems around delivering social services. So I want to tell you a story about one of the governments that we worked with. And specifically, I want to tell you a story about Seattle and how Seattle is using contracting, this pretty sort of simple mechanism, to overhaul their approach to solving homelessness. I'm going to tell you a little bit about the crisis in Seattle. I'm going to tell you about some of the challenges that the contract structure, that their data systems presented to them that made it really hard for them to solve this. And then I want to tell you a little bit about a pilot that Seattle has been embarking on to try and overcome these challenges. So in late 2015, Mayor Ed Murray of Seattle had a problem. Homelessness in Seattle was up 60% over the past decade. And yet no one could tell him conclusively why or what the city was doing wrong. By November of that year, the problem had gotten so bad that the mayor declared a state of emergency to raise awareness about the severity of the problem. But it wasn't as if the city hadn't been tackled this seriously. They had a 10-year plan in place to end homelessness in the city. And by the end of that 10 years, the problem was worse than when they started. They funded dozens of providers across the city to deliver shelter services, deliver case management, to try and deliver preventative interventions to families at risk of homelessness. And spending on those services had almost doubled over the last decade as well. And yet, despite this work, the city still couldn't answer the fundamental question facing the mayor. Why was homelessness going up despite spending going up? Was it because of scarce, affordable housing in the Seattle area? Was it because jails and substance abuse treatment providers were not effectively discharging individuals? Was it because the generosity of services in Seattle was attracting individuals from neighboring communities? Was it because our counts weren't perfect? Designing effective policy solutions requires us knowing the answers to these questions. And the disconnected structure of the homelessness service system in Seattle prevented them from being able to even start to begin to have these answers. To help address these challenges, Seattle asked for help from the Government Performance Lab as part of Bloomberg Philanthropies What Works Cities initiative that you heard a little bit about before. And this work began by trying to unpack what was going on. And there are three big challenges. First, the city had 176 contracts across 60 different service providers for homelessness services. One provider alone had 18 contracts with the city. And each of these contracts was highly prescriptive about the nature of homelessness services that funding could address, the target population of who could be served, whether it was perhaps a single mom or a veteran. And with each of these target populations came requirements about metrics that the provider had to report on, which were different for every contract, and restrictions about how the funding could be used. So when the single mom, who was also a veteran, showed up for services, those services had to be managed independently from the funder. They couldn't pay for things together. They had to be staffed independently. This is obviously burdensome for the provider. This is also really confusing for the client. Second, the data systems that potentially could have enabled the city to begin answering some of these questions about homelessness were disconnected, were siloed. This is not news to anyone. There were 4 different systems that had emerged in Seattle. The Homelessness Information Management System, which in theory was the comprehensive system that was designed to collect information from every provider about what services homeless individuals and families got, was unreliable. Providers had to double enter data into their own case management systems and HMIS, and it was just hard, and it took a lot of time. And so HMIS was incomplete, and so the city didn't manage towards it, and they created 2 other reports to try and get the information that should have been in HMIS, and suddenly there were 4 systems, and it was self-perpetuating for providers, because if the city isn't using HMIS, why are they going to enter data into it? And as a result, this disconnected system didn't allow Seattle to be able to track individuals through their homelessness experience. We couldn't tell whether there were a small group of individuals who were consuming lots of services, whether people who we thought had been housed were returning to the system, returning to homelessness after only a few weeks. Thirdly, the way that the city partnered with providers was oriented around activities, a lot of the themes that we heard from today. Providers were asked to report on the number of meals served, the number of individuals who spent a night in a homeless shelter, the number of showers that were taken in a given night. These all things are important, certainly, but they don't help us understand our progress towards what we ultimately care about: housing people stably and preventing people from becoming homeless when we can. These problems, these challenges, they're not unique to Seattle. They're not unique to homelessness. In fact, Seattle's Human Services Department is one of the highest performing in the country, committed to data-driven work, committed to being forward-thinking about policy solutions. And yet, again and again, we at the Government Performance Lab see governments treating their contracts and their contract management as a mechanism for preventing fraud and abuse, something that needs to be overcome, something that needs to be gotten through, rather than sort of strategic opportunities to think anew about how service providers and government can together work on solving the things that we're aiming to solve. One of our government partners has called this phenomenon pay and then pray. So what can we do about it? So with help from the Government Performance Lab, Seattle embarked on a pilot to try and transform its contracting to ultimately solve homelessness. There were 3 big things. First, they consolidated contracts. So they reduced by 2/3 the number of contracts that providers had with the city. This simple step unleashed flexibility in how they could use dollars. So suddenly they could use dollars on the things that actually could help keep people housed or get them housed, whether it's paying for interview clothes, paying for a security deposit, paying for certification to get a food handler's license. The second was that instead of having these ad hoc metrics that were different for every contract, they created a standard set of 6 performance measures that were linked to the things that the city cared about most. So now every provider gets measured upon the number of families that they prevent from becoming homeless through some preventative intervention, the number of families who get housed, the number of families who stay housed, the number of families and individuals who don't stay housed, who return to homelessness, and then barriers that are busted, things like getting a license or getting enrolled in public benefits. The third piece was changing the nature of the relationship between providers and government. So instead of looking at their contract management as a focus on making sure that there's no fraud or abuse in how our dollars have been used, Seattle is now embarking on high-frequency, data-driven meetings with its providers. We're focusing on creating the feedback loops to continually improve. So every month, Seattle's contract managers and providers sit down individually together, and they look at progress along these six metrics and troubleshoot program-specific problems. Then once a quarter, executives from all of the providers across the system get together with leadership from government, and they look at population-wide outcomes and identify opportunities to shift the system as a whole. So through this combination, Seattle now has insight into how resources are being used and what programs are working, and can make smarter decisions about how to allocate resources across the service array. We also are learning what's working and are identifying the best practices that can be shared with other providers. And lastly, we're establishing the foundation around the data infrastructure to answer some of those questions that the mayor asked at the beginning. The early results are promising. Of the pilot providers, one of them reported more of a 50% increase in the number of placements into permanent housing during the first 6 months of the pilot compared to the second 6 months. And the mayor was so encouraged by this results that earlier this summer, he announced a new request for proposals for the entire homelessness system that would spread these results-driven contracting practices across the entire system. So it's hard. Governments fall into this pattern again and again of focusing on getting the money out the door and doing it in a way without fraud and abuse, but not emphasizing enough what happens otherwise. Seattle gives us a perspective on a different way, that with collaborations around data and around results, that on any number of issues, we can begin to move the dial. Thank you.
Thank you, Scott. And Lisa and Tyler and Eshauna, can you come on up? We're going to do some Q&A. We've got about 10 minutes before the break.
Great. I have a number of questions. I'll give you 3 to start, and you guys can decide how to respond. For Dr. Fitzpatrick, you're up. What about the role of home and community-based services within your vision, and how are those organizations supported? The second question, improving health, improving education, ending poverty could each get us closer to the outcomes we desire. Our fields are guilty of spending time drawing people to our cause. Glad people are on board with collaboration. How can we funnel our energy towards a common cause? And the third question, can funders support the shift to paying for outcomes, or does that have to start with governments?
Lisa, you want to take the first one?
Sure, but I'll just say something quickly about the last one. Anybody can do it anytime. Don't wait for government. You see, it's taken this long for government to move. So the question about how you incorporate what I call the wraparound services, the housing support, food support, employment, social support, this is really important, particularly now in the health sector, because we are shifting toward value-based purchasing, which is we are looking for outcomes. We're looking to pay for outcomes versus outputs. And at our program here, I didn't talk about DC Medicaid. I'm not here representing DC Medicaid today, but we do have a program we've just launched this past summer to pay for those wraparound services. The program is called My Health GPS. And the idea is if you incentivize healthcare providers, and most of ours are federally qualified health centers, if you incentivize them with additional payments on top of the payments they already receive, then we can pay for these types of services. So we're hoping that this will lead us down the path toward integrated chronic care that includes behavioral health and includes a lot of those social supports you're asking about.
I may take a cut at the first one and the third one really briefly. Providers who are going at risk or at risk for care know that when they care for someone with diabetes or hypertension who are lower income on Medicaid and have a lot of social and non-medical needs, that they need to increasingly make the assessment of non-medical needs and referral a standard of care. That needs to become a standard of quality. But beyond that, then, if you're going to make a referral to a community-based organization, you got to pay for it. You can't just push it out on the community. So what we see starting to happen is beginning to look at contractual relationships with community providers to meet the need to reduce preventable utilization, right? The logic of a health plan, not to reduce health, but to reduce preventable utilization. But it takes the kind of data that Eshauna was actually talking about to really get there. But the future is moving to contracting with community-based organizations around those non-medical needs as part of shared risk arrangements. That's why we engaged Nonprofit Finance Fund to help build the capacity of the nonprofits in the community to be able to be in those kinds of relationships. And as a funder, we need to be seeding the innovations and testing and creating demonstrations that are proof points so that it can begin to be part of contracting and regular payment mechanisms. But that's the role of funders, is to seed it, prove it, and then move it into market mechanisms.
Thank you. I wanted to take a stab at the second question I think it was about how it can be one cause and not sort of how do we not split out into our own sort of issues. I had the opportunity to do some collective impact work before coming to Urban Alliance, and I do think there's something there with sort of this. If we all care about healthy communities, so having this continuum where we know early childhood is important, middle school transition, high school, workforce, and being able to come together as a community and us to be the ones to say, we have some programs that aren't moving the needle, and how can we go to our funders and say, what can we do together about this? I'll steal a line from Jeff Edmondson, who is part of the Strive Network, and he used to say that we're guilty of being program rich but systems poor. So how can we come together better around charting what each of us do best and what's really working, and then create the right kinds of resources for our communities? I think that's a way to think about it.
So I'll take a swing at the question of does government need to start this, or can funders start it? So what strikes me is an experience that we had in one government agency that will go unnamed here, where the government was thinking about, was planning to purchase a set of community-based services. And this was in a foster care context, and specifically about visitation. So these are services that are put in place when kids are in foster care. We put in place visitation to help build the parenting skills necessary to reunify families. And the department was thinking about rebuying those services, and discovered sort of halfway down this path that one of the foundations, the community, was about to go fund a large evaluation of visitation programs that all the providers had asked for. And what struck me was how discoordinated these two conversations were, and that money from a foundation to evaluate this program and figure out what was working in visitation in this context and what wasn't would have been unbelievably valuable for government. if it was linked to the policy questions that the department had. But instead, it was sort of designed and funded completely outside of the department's context. And so we're going to learn a little bit, but ultimately it's not going to drive the decisions that the state makes about how they allocate resources as much as it could were that conversation more well integrated. And I think the lesson a little bit is that, you know, I spend my days sitting in government agencies, and I certainly know that they can be frustrating places, especially for outsiders to figure out how to get insight to. There are people like all of you in those agencies around the country and looking for partners on the outside. Don't give up on our state agencies. Reach out to them. Try and find those people so you can do that funding in a coordinated way.
Can I just say one more thing related to the evidence, though? We already know a lot. We know a lot that could give us enough comfort to move forward, particularly funders. When we started our nonprofit, it was very difficult to receive any funding because one of the first questions you have to answer is how much funding have you already raised? Well, you have to start somewhere. And the RCT is beautiful. Yes, it's the holy grail. But do you know how long it takes to implement an RCT, even design an RCT, and we are ignoring a lot of the data we already have. So I'm reiterating a point I made to particularly funders. The risk is even greater than what you think you're risking, but if you want to get to the place we're talking about, you don't have to wait for the RCT.
Well, that's a great point to end on. I wish we had more time for Q&A, but we were out of time. Please join me in thanking all the speakers.